Okay, I'm gonna do a little non-scientific experiment. AI versus doctor. I'm gonna go through a case on human DX and give differential. No explanation. We'll see who wins. First case, 76-year-old woman presents with lethargy. Patient is brought in by family members as she is confused, lethargic, and hypoglycemic. They found the patient in her bed, hard to arouse, finger stick glucose 48, gave juice, and brought to the ER. Per family, the patient has 1 week of generalized constant worsening abdominal pain, has been seen in the 2 ERs this week and had 2 contrast CTs of the abdomen and pelvis. The first showed mild diverticulitis, so she was prescribed 1 week of oral ciprofloxacin and metronidazole. A second CT 4 days later was read as normal. Symptoms did not improve with antibiotics. Hypoglycemia, diverticulitis, small bowel obstruction, large bowel obstruction, perforation, abscess, peritonitis, constipation. Let's see what the AI says. I'm using Qwen 3.6. Okay, so the AI said sepsis-associated hypoglycemia with intra-abdominal source, fluoroquinolone-induced hypoglycemia from ciprofloxacin, adrenal insufficiency or adrenal crisis, and insulinoma, hepatic failure, hepatic insufficiency, non-islet cell tumor, hypoglycemia, hypopituitarism, starvation or malnutrition, occult intra-abdominal infection despite normal CT, such as mesenteric ischemia or inflected fluid collection, and then alcohol-related hypoglycemia. Next, aliquot. Past medical history includes type 2 diabetes with a recent hemoglobin A1C of 7%, hypertension, hyperlipidemia, CKD2. Home meds include benazepril, metformin, carvedilol, furosemide, glimepiride, rosuvastatin. You can definitely see some potential for medication adverse effects. So electrolyte abnormalities like bradycardia, hypotension, the combination of metformin and glypiride for the increased risk of hypoglycemia. So we can add those to the differential, but not much new information here. All right, physical exam. Vital signs show temperature of 96.9, blood pressure 78 over 44, yikes. Heart rate of 57, respiratory rate of 30, setting 100% on room air. In general, she appears sleepy but stirs the voice, follows simple commands, answering yes/no questions. HENT, no JVD, dry mucous membranes, no icterus. CV, bradycardic, regular rhythm, flat, JVP, no peripheral edema. Lungs clear to auscultation, tachypnea with increased work of breathing, abdominal, normal bowel sounds, soft, diffuse mild tenderness to palpation, no distension, rebound, or guarding. Neuro is limited due to mental status, but no obvious asymmetry or deficits. Cardiogenic shock, septic shock, hypovolemic shock is probably not the peritonitis or a bowel perforation. Let's see what the AI says after the physical exam portion. Adrenal crisis, sulfonylurea-induced hypoglycemia, sepsis, CKD-related hypoglycemia, insulinoma, non-islet cell tumor, hypoglycemia, hepatic failure, hepatic insufficiency, hypopituitarism, and removed intra-abdominal infection based off that, I guess. All right, let's see what the next aliquot shows. Labs, WBC 11,700, 69% PMNs, 3% bands, hemoglobin 10.4 and stable, platelets 273,000. BMP shows sodium of 133, potassium of 6, which is elevated, chloride of 97, bicarb of 7, BUN of 99, creatinine of 12.52 from 1.2 1 week ago. Okay, so she's in acute renal failure. Normal hepatic function panel, lipase, procalcitonin, UA. ABG is with a pH of 7.01, PCO2 of 20, a PO2 of 90 on room air. Lactic acid is greater than 13.5. APAP and salicylate levels are normal. Acute renal failure, metabolic acidosis, lactic acidosis. We also have to consider type A versus type B lactic acidosis. Type B would be a metformin-associated lactic acidosis versus type A, which is the one that's associated with hypoxia and sepsis. Let's see what the AI says. Now, the first differential it offers is septic shock with lactic acidosis, profound hypotension, elevated lactates, AKI, severe metabolic acidosis. Second is acute adrenal crisis. Third is metformin-associated lactic acidosis, sulfonylurea-induced hypoglycemia, hypovolemic or distributive shock with ATN, acute mesenteric ischemia, insulinoma, and non-islet cell tumor. All right. Imaging. Chest x-ray, abdominal x-ray, normal. Echocardiogram, hyperdynamic left ventricle, otherwise normal. ICU course. Admitted to the ICU for shock requiring 3 vasopressors, started on broad spectrum antibiotics, CRRT, and a bicarb drip. Blood, sputum, and urine cultures all negative at 48 hours. Okay, so let's see what the AI says with that information, see if they add anything to the differential. I'm not adding anything at this point. Okay, so the AI thinks now the number 1 diagnosis is metformin-associated lactic acidosis. 2, acute adrenal crisis. 3, culture-negative septic shock, possibly from an intra-abdominal or other occult source. Acute mesenteric ischemia, and then lastly, sulfonylurea-induced hypoglycemia. Let's do the last aliquot. Additional info, lactic acid level remained over 13.3 for 48 hours, even as hemodynamic state improved and pressors downtraded. So it's looking like that, metformin-associated lactic acidosis. Let's see what the final diagnosis is. If I can get this thing to work. Let me just make sure. I guess I put in medication side effect, which would kind of cover that, but let's just make sure we have it specifically. Metformin, lactic acidosis. I don't even know if they have it here. Let's see. If not, we'll just have to put metformin adverse reaction. Metformin adverse reaction as the number 1 diagnosis. All right, let's see. I think, that would definitely explain all of her symptoms and recurrent presentations. So let's see the final answer. Metformin-associated lactic acidosis. Good job, AI. You beat me.